Talk about treatment of drug-addled people. So let's go ahead and get started. Chapter 9. This is the last chapter in the book. I think it's the last chapter in the book. But we have one more lecture to do. We're going to talk about pharmaceuticals that you might come across. Chemical dependency is more prevalent and has a greater impact on society than mental illness. 26% have any mental disorder every year. 16.4% have anxiety disorder every year. 7.1% have mood disorder every year. 1.3% have schizophrenia every year. There are also nervous system diseases, brain tumors, physical head injuries. But 22 million Americans, 9.1%, abuse or are dependent on alcohol or illicit drugs. 29% of the population suffers from nicotine addiction. 2 to 6% of the population suffer from gambling addiction. Many see chemical dependency as the number one continuing physical health problem in the United States. 440,000 Americans die prematurely every year due to nicotine addiction. 53,000 Americans die from secondhand smoke. 130,000 Americans die prematurely every year from alcohol usage and its associated diseases. 35 to 40% of all hospital admissions are due to nicotine-related health problems. 25% of hospital admissions are related to health problems related to alcohol. Last year, 69,029 people died of an overdose on drugs. There were 48,320 opioid overdose deaths. Nearly half of all overdose deaths, 47%, were due to fentanyl or other synthetic opioids besides methadone. More than 1 in 5 of all overdose deaths, 22%, were due to heroin. There were 20,709 overdose deaths from other drugs than opioids. More than 1 in 5 of all overdose deaths, or 23%, were due to cocaine. An estimated 1 in 5 of all overdose deaths were due to methamphetamines or other psychostimulants with abuse potential. For the past several years, West Virginia has had the highest death rate from drug overdoses of any state, with a rate of nearly 58 overdose deaths per 100,000 population in 2017. Comparing that to the COVID-19 crisis, New York currently has a death rate of, when I wrote this wrote this lecture, New York has a death rate of 275 per 100,000, while New Jersey has a death rate of 299 per 100,000, and New Mexico has a death rate of 209 per 100,000. Arizona is right in the middle at 249 per 100,000, and of course that is at the apex of the COVID outbreak. Research is currently being conducted on treatment techniques. One direction that research is taking is the use of medications to treat detoxification, control withdrawal symptoms, such as phenobarbital for alcohol withdrawal, antipsychotics to control stimulant-induced psychosis, reduce craving, bromocriptine and bupropion for stimulants, naltrexone, buprenorphine, and clonidine for heroin, naltrexone and acamprosate for alcohol. Promote short-term and long-term abstinence, substitute medications that are less damaging, nutritional supplements, antidepressants. Research that is currently being conducted, researchers are using imaging machines and other diagnostic techniques to visualize the structural and physiological effects of addiction on the human brain. CAT scans, MRIs, functional MRIs, PET scans, SPECT scans, single photon emission computerized tomography scans, development of more effective tools to diagnose addiction. The CAGE test is for Addiction Alcohol Severity Index, and the American Society of Addiction Medicine Patient Placement Criteria. These are all being used now. Researchers are looking for evidence-based best practices in treatment. 13-point criteria to measure treatment efficacy. One randomized clinical trial has shown the treatment effective. Treatment shows effectiveness in several replicated studies. The treatment targets behavior that is generally present. The treatment can be used in similar regions and populations. The treatment is feasible, inexpensive, and group supported. The key components of the treatment are easily understood. The treatment is accepted by providers and clients. The treatment is based on a clear and articulated theory. The method of treatment ensures consistency of delivery. The treatment can be evaluated. The treatment shows good retention rates for clients. The treatment addresses cultural diversity in different populations. The treatment can be used by staff with differing training. The National Registry of Evidence-Based Programs and Practices currently identifies 160 treatments and programs that have been shown to be effective for the treatment of addictions. Unfortunately, this emphasis on evidence-based treatments and programs decreases the appreciation for the practice-based treatments. Alcoholics Anonymous and Narcotics Anonymous, both of these are 12-step fellowship models. Research supports coerced treatment as being just as effective as voluntary treatment. All 50 states operate drug court programs. 100,000 people have entered drug court with a success rate of about 50 to 65%. Felony offenders are kept twice as long. Court programs maintain closer supervision. There is a continued threat of incarceration. The Drug Treatment Alternative to Prison program in New York have reduced the rate of rearrest by 33%, reconviction rates by 45%, and return to prison rates of 87%. Return to prison rates are known as recidivism. Most of these programs have shown a reduction of cost as compared to incarceration costs. Research into the lack of resources to provide treatment that have been proven effective. This is what we're researching now. On the average, states spend about 13% of their budgets to combat the effects of drugs, alcohol, and cigarette abuse. Research shows that for every treatment dollar spent, the state saves between $4 to $39 on prison costs. Lost time on the job, health problems, and extra social service costs. Sufficient treatment doesn't exist for those that want it. There are only so many slots and monies allocated for treatments. In fact, treatment facilities actually declined during the Bush years from 15,230 in 1999 to 13,367 in 2005 and 13,585 in 2017. Research is joining the debate between the abstinence-oriented recovery philosophy and the harm reduction philosophy. Research in the 1990s found that 95% of the recovered addicts who did not practice a complete abstinence philosophy went into full relapse. Let me repeat that. Research in the 1990s found that 95% of the recovered addicts who did not practice complete abstinence went into full relapse. In other words, it only worked for 5% of the people. So complete abstinence is the only way to do it. Otherwise, you're going to relapse. But many of the people in addiction treatment fields see harm reduction as a more realistic alternative. Drug replacement therapy, needle exchange programs, designated driver non-drug using driver programs, substituting less harmful drugs for more harmful ones, providing testing of drugs for users so they won't use deadly levels without knowing, decriminalizing legalizing drugs, controlling drinking and drug use through behavior modification. The California Drug and Alcohol Treatment Assessment, CalDATA, study was conducted in the middle of the 1990s to determine if the treatment programs being used in California were effective and cost-efficient. The study followed 1,850 addicts for 3 to 5 years after the addiction treatment. No additional crimes were seen in 74% of the addicts followed. Complete abstinence was practiced in just under 50%. The savings for the state was between $3 to $6 depending on the treatment that was used. Other results from CalData: the treatment was the most effective when the patients could be treated for at least 6 to 8 months consecutively. The shorter the time in treatment, the poorer the outcome. Group therapy worked better than individual therapy. The type of psychoactive substance used made a difference. When alcohol was a primary drug, treatment was twice as effective as that for heroin. Cocaine treatment was less effective than alcohol, but more effective than heroin. Treatment outcomes were better if it was sensitive to cultural norms. Drug Abuse Treatment Outcome Study, DATAS, was conducted from 1991 to 1993, tracking 10,010 drug abusers in 100 treatment programs in 11 cities. The study ran pre- and post-treatment levels on drug use, criminal activity, employment, and thoughts of suicide. Treatment programs included outpatient methadone programs, long-term several months, residential programs, short-term up to 30 days, inpatient programs, and outpatient drug-free programs. DATAS results showed that use of all drugs after treatment was reduced 50 to 70%. The 2 residential programs seemed to have the greatest effect. The more severe the patient's problems, type and level of drug used, the lower the retention rate. Most of these patients claimed they didn't get the level of care that they needed. The study also found a trend toward a reduction of services offered. Treatment episode data sets, TEDS, from the Drug and Alcohol Services Information System, DASIS, is funded by SAMHSA and collects data on patients from all 50 states, the District of Columbia, and Puerto Rico. Part of this research is the National Survey of Substance Abuse Treatment Services, NSATS, which looks at the treatment facilities. Treatment Research Institute at the University of Pennsylvania wrote a study in 2005 that did a meta-analysis of more than 1,000 addiction treatment studies over 2 decades. The study determined that the savings ranged from 33 cents to $39. Savings came from decreased crime and post-treatment reduction of health care costs. There are 2,193,798 Americans in federal, state, and local prisons. 11% of these prisoners are women. There are 5 million Americans on probation or parole. 57% of federal inmates and 20% of state inmates are serving sentences for drug offenses. 11.5% were arrested for drug abuse violation, 1.6 million arrests. 1.2 million of these were for possession. 40 to 65% of those in prison committed crimes under the influence of alcohol or drugs. 24% of the people on probation were arrested for a drug law violation, and 17% were driving while intoxicated. The average time served was increased from 22 to 27 months. Despite the high percentage of inmates incarcerated for drug-related problems, there are only slots for about 10% of those with serious problems. Even though 94% of the federal prisons have treatment programs, even though 56% of the state prisons have treatment programs, even though 33% of jails provide some on-site substance abuse treatment for their inmates, fewer than 17% of incarcerated offenders with drug problems have received treatment while in prison. No single treatment is appropriate for all individuals. Selecting the right treatment for individual situation is key in success. Treatment must be available when it is needed. Effective treatment attends to all of the individual's needs, not just their drug use. The treatment plan must be assessed continually. The individual must remain in treatment for an adequate amount of time for effectiveness. Individual and group counseling as well as behavioral therapies are critical to effective treatment. Medications are an important component of treatment for many patients. Addicted and mentally ill individuals must have both disorders treated in an integrated way. Detoxification is the first stage in addiction treatment. Of itself, detoxification will not change long-term drug use. Treatment need not be voluntary to be effective. Possible drug use during treatment must be monitored continually. Infectious diseases that might have been contracted while using drugs should be screened: HIV, hepatitis B and C, and tuberculosis. Recovery might require multiple treatment episodes. Treatment in the criminal justice system maintains a similar set of treatment principles. Drug addiction is a brain disease that affects behavior. Recovery from addiction requires effective treatment. Treatment must be long enough to produce stable behavioral changes. Assessment is the first step in treatment. Drug testing must be done during treatment. Treatment must also aim to change criminal behavior. Treatment plans must be aware of correctional requirements. Continuity of care must be continued when the individual re-enters the community. Treatment should include rewards and sanctions. Integrated treatment should be developed for individuals suffering from addiction and mental illness. Medications should be an important part of treatment. Chronic and serious medical conditions should be prevented or treated. Most treatment specialists understand that addiction treatment is a lifelong treatment for the addict. The primary goal for addiction treatment is motivation to abstinence, creating a drug-free lifestyle, supporting goals, enriching job or career functioning, optimizing medical functioning, optimizing psychiatric and emotional functioning, addressing relevant spiritual issues. Programs tend to be selected based on cost, familiarity, location, and convenience of access. Evidence-based assessment tools are mandated to match addicts to appropriate level of care. The DSM-5 maintains 2 diagnoses that deals with substance-related disorders, which relies on pattern and duration of use and the negative impact on the individual. And these 2 diagnoses are substance abuse and substance dependence. Diagnosis assessment tools: the National Council on Alcoholism criteria for diagnosis of alcoholism and its modified criteria assesses 35 items through a structured interview to determine physical and clinical parameters, behavioral, psychological, and attitudinal impact. The Addiction Severity Index, the ASI, 200 items, covers 6 areas of use and abuse. A Michigan Alcoholism Screening Test, the MAST, 25 yes or no questions that deal with the negative impact of alcohol on the user. A brief MAST exists that only has 10 questions, and that's used in emergency rooms. MAST test for alcohol and drugs. MSAP's Substance Abuse Problem Scale. SMAST G's short version of the MAST for geriatrics. The CAGE questionnaire are 4 questions. Have you felt the need to cut down on your drinking? Do you feel annoyed with people complaining about your drinking? Do you ever feel guilty about your drinking? Do you ever drink an eye-opener in the morning to relieve the shakes? And we're going to see that question a lot. The 10-item screen that cover, this is the audit, the AUDIT, the Alcohol Use Disorders Identification Test. It has 10 items that cover frequency, daily amount, incidence of 6 or more drinks, inability to stop, inability to fulfill normal expectations. There it is again, the eye-opener in the morning. Guilt, remorse, blackouts, brownouts, suffered or injured someone while drinking. Others suggested moderating your drinking. CRAFT, C-R-A-F-F-T, stands for driving a car while high, use to relax, use alone, forget things while high, family and or friends ask you to cut down, and have gotten into trouble while on alcohol and drugs. The RAPS-4, the Rapid Alcohol Assessment Screen, has 4 items: guilt, blackouts, failing normal expectations, and do you drink an eye opener in the morning? The SASST, the Self-Administered Alcoholism Screening Test, has 35 yes or no questions. The TACE has 4 questions. Tolerance, annoyed, people are annoyed with you, do you feel like you need to cut down, and do you use an eye opener in the morning? Tweak, you've built up a tolerance to alcohol, you're worried about your alcoholism, you use an eye opener in the morning. Amnesia, and do you feel like you need to cut down or cut back on your drinking? The DAST drug abuse screening test has 20-item scale. The PESQ, the Personal Experience Screening Questionnaire, has 18 questions. It determines problem onset, psychological and social functioning, problem severity, and frequency of use. The 4 Ps plus, parental history of alcohol or drug problems, partner's use of alcohol or drugs, past personal history of alcohol use, and use of alcohol or tobacco the months before your pregnancy. And this has to do, of course, with a woman that is pregnant. ASAM PPC-2R, the American Society of Addiction Medicine Patient Placement Criteria Revised, evaluates 6 dimensions of problem areas and illness severity: acute intoxication, withdrawal potential, biomedical conditions and complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use or continued problem potential, recovery environment. These are matched to 4 levels of care: outpatient treatment, intensive outpatient partial hospitalization, residential inpatient treatment, medically managed intensive inpatient treatment. Treatment options from cold turkey or white knuckle dryouts to medically assisted detoxification. From expensive medical or residential approaches to free peer groups, 12-step programs, or social model group therapy. From outpatient treatment to halfway houses to residential programs. From long-term residential treatment, 2 years or more, to 7-day hospital detoxification with aftercare. From methadone maintenance, replacement therapies, or other harm reduction techniques to acupuncture, aversion therapies, or a dozen other treatment modalities. How do we select a program which is best for our needs? Medical model detoxification programs can either be inpatient, residential, or outpatient, supervised and managed by medical personnel. Its medications can be administered along with more traditional counseling. These tend to be the most expensive types of programs. They can last as long as you need them, up to 6 months. And of course, I've got a picture of the Betty Ford Center here. Betty Ford was President Gerald Ford's wife, and it turned out that Betty Ford had a alcohol addiction problem, and she's the one that started these clinics. And they are all over the United States now, and they help people detoxify and get over their addiction. They're kind of expensive, and for that reason, a lot of celebrities have used Betty Ford to get clean. Residential inpatient treatment tends to be short-term, up to 28 days. Intensive counseling, medically managed, drug counseling. There's a movie called 28 Days with Sandra Bullock. And it's about one of these treatment programs. And it's really kind of fascinating watching how she starts out as very cynical, and then by the end she is ready to clean up. Partial hospitalization and day treatment, outpatient medical model programs, 4 to 6 hours a day, patient lives at home, detoxification counseling, and drug education. Methadone maintenance programs cost between $4,000 to $6,000 per year. Office-based medical detoxification and maintenance treatment for opiate abusers can be done by qualified medical practitioners. Social model detoxification programs are non-medical. There are two types, non-medical or residential or outpatient. Social model recovery programs, cognitive behavioral therapy is used. Insight-oriented psychotherapy is also used. You have group therapy, problem-solving groups, and then, of course, the 12-step programs as well. Therapeutic communities, self-contained residential programs, long-term 1 to 3 years, habilitation or rehabilitation of the total individual, changing negative patterns of behavior and thinking as well as feeling that predispose drug use, development of a drug-free lifestyle. That's what they're aiming for. 3 major stages: induction and early treatment, committing to the recovery process, primary treatment, and then reentry into the community at large. Halfway houses permit addicts to keep their jobs and outside contacts while being involved in a residential treatment program. They receive educational and therapeutic interaction. They live within the safety of the facility. External triggers are minimized. Non-work days are reserved for intensive interaction. Several new religious movements and faith-based treatment initiatives use the halfway house approach. Sober living and transitional living programs are generally for clients who have completed a long-term residential program. They may live in apartments or cooperatives for groups of recovering addicts. Minimal to moderate treatment structure. It provides a structured environment to help the addict re-enter the broader society from the structured support. Harm reduction programs, replacement therapy, controlled drinking, partial detox clinics, and sobering stations. And of course, that is for someone who isn't in, hasn't decided to go into treatment yet. So we will see if we can help them, and then eventually we'll get them to complete abstinence. Recognition and acceptance of one's addiction may come in 2 ways: self-diagnosis, usually after the addict has hit bottom, and intervention. Addicts and alcoholics rarely accept the diagnosis of their addiction from others. Coerced treatment via the criminal justice sanctions can actually help addicts realize that they have hit bottom. Hitting bottom, addiction is a progressive illness that leads to severe life impairment and dysfunction when left to proceed without disruption. The earlier an addiction is recognized, accepted, and treated, the more likely the addict will have a rewarding life and good health. Everyone has a different sense of what hitting bottom is. The individual does not have to hit bottom to accept that they have a chemical dependency problem and participate in treatment. Overcoming denial is the essential first step in all treatment. Denial is the refusal to acknowledge that the negative impact that the drug use is having on the individual's life. It is not uncommon for the medical profession to deny or overlook a patient's addiction. I can remember the first case that I dealt with was when I was in the Air Force, and it was a couple, and these are young kids. One was 19 and couldn't drink legally. This is before. Yeah, this is before they raised the drinking age to 21. So the guy was 21 and the young lady was 19. They were drinking a case of beer a night. Each one of them was drinking a case of beer a night. When they came in, of course, they were fairly non-functional the next day, and the Air Force decided that they were going to detox these people and see if they could rehabilitate them. And what happened was we brought them in, and we tried to detox them. We were at a base in Lubbock, Texas, and we tried to detox them, and it worked for the young lady, but it didn't work for the guy. So we had to send him down to San Antonio to get detoxed. But we got her okay. Part of the problem was that Part of the problem was that it was so expensive. They were buying a case of beer a night, and we weren't making that much money. It was kind of, and she drank Heineken, and it was like it was a lot more expensive than what he was drinking. He was drinking, I don't know, Schlitz or something, Budweiser, a cheaper beer. So yeah, we got it. We fixed her, but had to send him down to Wilford Hall in San Antonio. And when he came back, she broke up with him. So there you go. And that put him back on the bender. So eventually he lost his position in the military. The toxic effects of the drugs being used creates judgment and memory problems, making the addict the last person to recognize and accept their addiction. Addiction is the only illness that requires a self-diagnosis for treatment to be effective. Denial can be broken through by legal intervention, workplace intervention, physical health problems, pregnancy, mental health problems, financial difficulties. Referrals in the United States, self-referrals about 33.6%, the criminal justice system 36.1%, substance abuse providers 10.2%, healthcare providers 7%, schools 1.1%, employers 0.7%, other community referral 11.2%. Intervention strategies have been developed to attack the denial and drug abusers and addicted people. Two things that you need to show them in the intervention. The first thing is love. You need to show them that you love them and you want them to change. An intervention should always start and end with an expression of love and genuine concern. A lot of times interventions have to do with anger. That you got to put that away. You just need to show them that you love them. If you show them anger, what will happen is they will become very defensive. But if you show them love, it's really hard to be defensive about love. The facilitator, the intervention should be organized by a professional intervention specialist or a knowledgeable chemical dependency treatment professional. Intervention statements. Each team member will prepare a statement that he or she will make to the addicted person at the intervention. A declaration of how much they love, care for, and respect the user, specific incidents they have personally witnessed or experienced related to the addiction and the pain that they have personally experienced because of the incidents. Personal knowledge that the incidents occurred not because of the user's intent, but because of the drug's effects on the user's behavior. Reassurance of their love, concern, and respect for the user with a strong request that he or she recognize and accept the illness and enter treatment immediately. Anticipated defenses and outcomes. The facilitator prepares the team to deal with expected defense mechanisms, denial, rationalization, minimization, anger, accusations. Have the addicts? You need to have the addicts' bags packed and ready to go, because after the intervention, they need to go to treatment right away. Timing, location, and surprise are crucial components of the actual intervention. It needs to be in a neutral environment. It needs to be in a non-threatening environment. It needs to be private. The addict should be sober at the time. Evidence should include current incidents. Order of the statements should be rehearsed prior to the intervention. Contingency, whether the intervention is successful or not, the members of the intervention team should continue to meet after the intervention. There's always a possibility that an unsuccessful intervention will result in anger and rejection. And this is especially common with alcoholics. Alcoholics are amazing manipulators. Well, all drug addicts are, but especially alcoholics. They practice manipulation all the time. A lot of times that is their modus operandi, is the fact that they are able to manipulate the people around them, and that's how they're able to maintain their drinking. Treatment continuum. Recovery for the addict will be gradual as the client undergoes several changes, no matter which therapy is used. Initially, they'll go through detoxification. They'll have to be abstinent through this whole process. and of course they'll need to have long-term abstinence, and then they will need to understand that they are in continuous recovery. Once an alcoholic, always an alcoholic, and they need to abstain for the rest of their lives. Relapse needs to be accepted but not excused in recovery. Relapse should be aggressively processed by the client and the counselor to recognize its causes and identify strategies that might help to prevent future ones. I was looking at statistics on this. Relapse happens to 85 to 95% of the people that are addicted to something. That's a lot. And so you have to anticipate that they will relapse at some point. Now, this is the trick is to, if they fall off the wagon, they need to get right back on the wagon. Just because you fell off doesn't mean that you're a failure and you're never going to be sober again. You need to get back on the wagon right away, and you need to start a new chapter. Detoxification, it takes about a week to completely excrete a drug such as cocaine, and perhaps another 4 weeks to 10 months until the body chemistry settles down. And this is the biggest problem, is the fact that it hurts. It can hurt for as little as a month, but it can hurt for as long as 10 months. And this is why there is so frequent relapse. Substance that people relapse the most from is heroin. Not because heroin is so addictive, but because the feelings that you get from heroin are not, and they're not actually that positive a feeling that you get. It is the fact that when you relapse, it feels so good. That's the difference. The initial detoxification often includes a process called white knuckling, where the abuser stops taking the drug on their own and has to suffer through physical and mental withdrawal symptoms. Medically or chemically assisted detoxification is aimed at minimizing withdrawal symptoms. The need of medical detoxification will be based on the severity of addiction. Medication therapy for detoxification, clonidine dampens withdrawal symptoms of opioids, alcohol, and nicotine. Phenobarbital prevents withdrawal seizures and other symptoms of alcohol and sedative hypnotic dependence. Methadone is a long-acting opioid used in opioid detoxification. Buprenorphine is used for short-term opioid detoxification. Naltrexone blocks the effects of opioids. Psychiatric medications, antipsychotics, haloperidol is something that has been used. Antidepressants, tricyclics and SSRIs, tricyclics such as imipramine and desipramine, SSRIs such as Prozac and Zoloft. They've been used in initial detoxification of cocaine, amphetamines, and any other stimulant addiction. Bromocriptine, Parladel, amantadine, Simetril, and L-Dopa are used to treat the craving of cocaine and other stimulants. Compresate decreases alcohol cravings. Verniculine, Chantix, and bupropion, Zyban, lessens the cravings of nicotine. Nicotine patches can be used. Nicoderm, Prostep, it will lessen the withdrawal symptoms of nicotine. Nicorette helps lessen cravings. Antabuse prevents relapse by reacting to alcohol with nausea and vomiting. And amino acids lessen craving and withdrawal. Since addiction involves voluntary and involuntary activity in the brain, detoxification alone can lead to a successful treatment. The addict must also go through intensive counseling to change the way they think and feel about the addictive substance. The aim of counseling treatment is to break down residual denial. Treatment teaches the addict about the disease concept of addiction. Once the addict has been detoxified, the body's chemistry must be allowed to regain balance. The addict will go through endogenous craving brought about by the depletion of brain neurotransmitters brought about by the drug. The addict will also go through post-acute withdrawal symptoms, post-acute withdrawal symptoms, emotional and physical symptoms that appear after major withdrawal symptoms have subsided. Many persist for 6 to 18 months but have been known to last for up to 10 years. Pause is a major contributor to relapse, post-acute withdrawal symptoms. Pause is a result of a combination of brain neuron damage caused by drug use and psychological stress of living drug and alcohol-free after many years of drug-using lifestyle. It causes sleep disturbances, memory problems, especially memory problems, inability to think clearly, anxiety and hypersensitivity to stress, inappropriate emotional reactions and mood swings, physical coordination difficulties, because there has been damage to the brain from these drugs. Environmental triggers often precipitate drug cravings. Interpersonal factors, internal influences such as negative emotions and physical states that can be controlled by psychoactive substance usage. Interpersonal factors, external influences, relationship conflicts, social pressures, lack of support systems, negative life events, slippery people, places, and things like bars. Relapse prevention is part of every treatment program and should be part of every treatment program because, as I said before, 85 to 95% of people will relapse at some point and they need to get back on the wagon right away. Addicts learn to recognize their personal triggers, drug odors, seeing friends who use, having money in one's pocket, hearing a song about drugs. The addict must develop behaviors to avoid external cues. The addict is trained to be prepared with an automatic reflex strategy to prevent them from using their craving from being activated by the internal or external cues. Addicts start putting their lives back in order in the initial abstinence phase. Addicts need to build a support system that will give them continuing advice, help, and information. Long-term abstinence can only be maintained by most addicts with continued participation in group, family, and 12-step programs. The addict must accept the fact that addiction is chronic, progressive, incurable, and potentially fatal. Relapse is always a possibility, 85 to 95%. Compulsive drug users often switch intoxicants only to find that the symptoms resurfacing through another addictive agent. Experts suggest that the addicts stay away from all compulsive behaviors. Recovery can only be achieved by restructuring their lives and find things they enjoy doing that gives them satisfaction and natural highs instead of artificial highs they have experienced through drugs. Offering the addict a substitute dependency, exercise, remind the addict that one episode of drug use can lead to relapse, repairing the social and psychological damage that has been done, and restoring self-esteem. I think I've told you about my friend who was an alcoholic for 17 years. The way that he was able to stop drinking was by becoming addicted to gambling. And of course, he hit bottom, and then when he tried and when he recovered and stopped drinking, he picked up gambling to keep him from drinking. So anytime he had money in his pocket, he gambled it away. The problem was that sometimes he had other people's money in his pocket, and he still gambled it away. So this became a new problem for him. Individuals have the capability to produce the same feelings and sensations naturally that they get from drugs. Athletic competition releases the same neurotransmitters experienced with cocaine and methamphetamine. Runner's high activates the same receptor sites as opiates. Traveling or experiencing new environments activates the same novelty centers in the brain that are stimulated by marijuana. And one of the things that we need to remember is that now that marijuana is being legalized all over the United States, that this may become a new problem that we are seeing more and more often. Since it was illegal before, we weren't seeing as much marijuana treatment around the United States, but this is going to become one of the new problems that we have around the United States. Indicators of a successful treatment includes duration of continuous sobriety, ability to stay in treatment, completion of a treatment plan, family functioning, social and environmental adjustments, vocational or educational functioning, personal finance management, and criminal activity. Individual therapies explore the reasons for the addict's continuing use of psychoactive substances and identify all areas of intervention needs with the aim of changing the client's behavior. These are the types of therapy that can be used: cognitive behavioral therapy, reality therapy, aversion therapy, psychodynamic therapy, art therapy, assertiveness training, motivational interviewing or enhancement, social skills training. Motivational interviewing and motivational enhancement therapy. This technique uses a non-confrontational style to help them change ambivalence about drug use into the desire to change. Express empathy, allow resistance to happen and explore it. Develop discrepancy between what is wanted and what is had. Support self-efficacy. With motivational interviewing and motivational enhancement, the client will go through 5 stages. Pre-contemplation, where they will not admit that they have a problem. Contemplation, where the client begins to think that they have a problem. Determination, where the client decides to do something about their problem. Action, where the client chooses a strategy. And maintenance, where the client actively works on maintaining their strategy. And of course, all of you have gone through Introduction to Counseling, and this is the these are the 5. This is the 5 stages that we talk about in Introduction to Therapy, and one reason is because the individuals that wrote the book, they do drug therapy, and we talked about all of these types of therapies as well. Group therapy, except for group therapy. Group therapy helps the clients break the isolation that chemical dependency induces. Facilitated groups consist of 6 or more clients who meet daily, weekly, or monthly. Peer groups have the same structure as a facilitated group, but with less direction from the therapist. Self-help groups are not facilitated by a therapist, but are maintained by lay peers. Alcoholics Anonymous, Narcotics Anonymous, Crystal Meth Anonymous, Cocaine Anonymous, Marijuana Anonymous, Gamblers Anonymous, Overeaters Anonymous, Sexaholics Anonymous, and Debtors Anonymous. These are all types of self-help groups. Addiction is a family disease as it impacts all the members of the family. The addict's family is often ignored and neglected in the pursuit of the pleasure or oblivion that is caused by the drug. Addicts are very selfish people. Addicts are very selfish people. They are manipulators. Family members must accept the addiction as a treatable disease. The family must establish a drug-free family system. The family must develop a system for family communication. The family must process the readjustment. One of the problems with addiction is that not only is he manipulative, but the family becomes enablers, and of course that needs to change. All that needs to change. Family systems approach focuses on daily routines, family rituals, and short-term problem-solving strategies. Family behavioral approach focuses on the behaviors peculiar to family associated with drug use. And a lot of times what happens in families of addicts is that they create an environment where their need to use is supported by what's happening in the family. So if something negative has to happen in the family, that's the environment that they create. So they create a negative environment. Maybe it's the arguing between the mother and the father. So as long as she's arguing, he has an excuse to drink. or the children are misbehaving. As long as they're misbehaving, he has an excuse to drink. So the behavioral approach and the family systems approach, all of this these are things that need to change within the family. Family functioning approach seeks to repair the functioning of the family to prevent relapse from the addict. In other words, if he was using argument as an excuse, then being able to resolve conflicts without getting into an argument. Social network approach, the family breaks their isolation and develops skills to seek support in their recovery effort. A lot of times families are forced to isolate themselves because of the negative impact of the alcohol, so they isolate themselves from a social situation. Tough love approach, family sets limits for their interaction with the addict. Codependents are dependent on the addiction of the addict to fulfill some need that they have. The addiction may allow the non-addicted partner to control the relationship. And one of the things that you need to understand, and I hate to talk about this, but one of the things that you need to understand is a lot of times an addict will marry somebody who will support their addiction. So once things change, once they become less addicted, now the need that they had for that individual has changed, and potentially they will break up with that individual. Why? Because that really wasn't the person, that was the person that supported their drug use. So just because somebody gets married and they potentially have children, now that they are no longer alcoholics, they may realize that, wow, the only reason I married this person is because they would let me drink. And now that I'm not drinking anymore, I don't have the same feelings for this individual. I don't have there's no reason for me to be with this person. Happens all the time. And it's something that we need to be aware of and to be to respond to. The addiction may allow the non-addict to overlook their own shortcomings or problems. The non-addicted partner promotes the addiction and becomes part of the dysfunction. In order to promote recovery, the codependency must be articulated and their behavior must change. And a lot of times what will happen is the spouse will realize that things are going to change. It's not going to be like it was before. They're not going to like me as much as they did before. So I'm not going to support their recovery. Happens all the time. Families caught in a circumstance of addiction and denial will often dance around the problem rather than confront the addict head on. This refusal to deal with the problem actually helps the addict maintain their addiction. This form of mass denial perpetuating the addictive behavior is referred to as enabling. And it's not just the spouse. A lot of times it's the children as well, especially if there is abuse from the drunken addict or the addict that comes in inebriated. A lot of times the children will do things to create a situation where they won't get abused, and that'll be part of the game. Children of addicts develop enabling roles that eventually become ingrained as a maladaptive behavioral pattern that are perpetuated into adulthood. They include the model child, the problem child, the lost child, and the mascot child or family clown. The model child hides the dysfunction of their families by becoming high achievers and overly responsible. They are the biggest enablers for their parents' addiction because they take over the roles and responsibilities of their parents. The problem child reflects the behavior of their parents. These individuals have continual and multiple personal problems. They often participate in early drug and alcohol addiction. They demand and get what little attention the parents can give to their family. Lost children are withdrawn. They act spaced out as if there is so much going on in their minds that they can't acknowledge anyone else. They seem disconnected from life and any emotions around them. They are unable to form close friendships or intimate bonds with others because they avoid emotionally confronting issues. Family mascots or family clowns are able to avoid the family problems by trivializing or making jokes of serious issues. They tend to have many friends because of their humor, but only deal with life in a superficial manner because of their desire to reduce everything into something humorous, like this little boy. I love that picture. Ugh. As adults, children of alcoholics are isolated and afraid of people and authority figures because that's what they've been trained to do. Cops are bad because they arrest their father or mother or whoever. They arrest the addict when they become inebriated and try to drive home. So authority figures are negative, judges are horrible people, they are approval seekers and lose their identity because of it. They are frightened by angry people and personal criticism. They become or marry alcoholics or other addicted people because that looks like love to them. Their parents are telling them that they love them all the time. And of course they do, but so when they marry somebody, they want somebody that is very similar to their parents. You marry your mom. If you're a male, you marry your mom. If you're a female, you marry your dad. As adults, children of alcoholics feel guilty when standing up for themselves, become addicted to excitement and stimulation, confuse love and pity, and seek people who need to be pitied and rescued. They repress feelings from traumatic childhoods. They judge themselves harshly and have low self-esteem. They are reactors rather than initiators. Adult Children of Alcoholics is a 12-step program to help adult children sift through the emotional baggage of their childhood. They understand the disease of the addiction and develop forgiveness for their parents. They put themselves on the top of their priority list. They detach from love. They feel accept and express feelings and build self-esteem. They learn to love themselves. Now you got to remember that what was happening before is you had to become an enabler in order to get love from your parents or from the alcoholic. So now they learn to love themselves because before, if they acted negatively toward the addictive parent, then they withheld love. Polydrug use, aggressive treatment programs need to be developed to treat all of the client's addictions. Heroin addicts may also have a drinking problem. Many substance abusers may also maintain serious behavioral addictions. One problem will trigger the other addictive behavior, allowing the addict to drift from one problem to the other. Until both problems are addressed, neither can be taken care of. Methamphetamine abusers tend to be male, white, and gay or bisexual. Psychiatric symptoms that often accompany stimulant abuse include schizophrenia, paranoia, major depression, and bipolar disorder. Evaluation of the problem will have to be done in order to determine if it is caused by the abuse. Stimulant abusers tend to respond positively to traditional drug counseling approaches along with the following medications: antidepressants, antipsychotic medication, sedatives, nutritional supplements, dopamine agonists, anti-epileptic drugs. Long-term cravings for stimulants can be caused from a dopamine depletion. There are several medications that can stimulate dopamine release and stop the endogenous cravings. Exogenous cravings are often stronger than endogenous cravings and can be treated with counseling, group sessions, and desensitization techniques. Cocaine aversion therapy also can be used. Disulfiram will cause aversive physical consequences if cocaine is used. Abstinence is the only acceptable result from tobacco cessation therapy. Failure rate for tobacco cessation is higher than any other addictive substance. 70% of smokers want to quit, 46% attempt to quit each year. Success rates for the types of pharmacological treatment include nicotine patches, 17.7%, nicotine inhaler, 22.8%, nicotine gum, 23.7%, Zyban, 30.5%, nicotine spray, 30.5%, combination of any two, 28.6%, Chantix, 44%. Nicotine patches work so well because they give a steady rate of release of nicotine, the ease of compliance, the lack of toxic effects to tissues in the mouth, lungs, and digestive tract. Problems include cost, inability to alter the amount being absorbed, the length of time it takes to raise the nicotine level, 4 to 6 hours. If the user is smoking while wearing the patch, it may raise the plasma nicotine levels to dangerous levels. Nicotine gum has the advantage of raising the nicotine level rapidly and maintaining it for a number of minutes, about 15 to 30, which curbs the craving. The user seems to have more control over the dosage than with the patches. The user can chew too much gum and get an adverse reaction. The gum irritates the mucosal tissue in the mouth. The gum supports an oral addiction. Nicotrol, a nicotine nasal spray, is self-administered and reaches the brain in 3 to 5 minutes. It relieves the craving in a short time. The disadvantages to its use include irritation to the nasal passage, and it reinforces nicotine addiction. Nicotrol also has an inhaler that allows the fastest relief for nicotine cravings without inhaling all the other destructive chemicals in cigarettes. Nicotine lozenges actually contain 60% tobacco and deliver 1 milligram of nicotine and can be used wherever the individual cannot smoke. Withdrawal symptoms from nicotine include anxiety, depression, and craving. These can be reduced by using medications, Chantix, Zyban, benzodiazepines, buspirone, Prozac, or clonidine. Tobacco cessation therapy is similar to that of any psychoactive substance, but has a lower rate of success at from 15 to 30%. The techniques used include desensitizing the smoker to the environment, practicing alternate methods of calming oneself, avoid environments where smoking is rampant, find other ways of getting the small rush or mild euphoria, teach the user the physiology of nicotine and the medical consequences of smoking or chewing tobacco. Teach the user the extraordinary benefits of quitting. And of course, now that it's illegal to smoke in public places, that you can only smoke in private places, this has helped smoking cessation. Heroin detoxification is done with methadone and buprenorphine, where they are administered in place of the heroin and then slowly tapered off. After detoxification, naltrexone will be administered to decrease cravings and ensure abstinence. Follow-up treatment is conducted in individual counseling sessions, group sessions, and self-help groups. The individual will be required to attend counseling sessions daily for 4 to 8 weeks after detoxification. The key to recovery from opioid addiction is learning a new lifestyle. Methadone replacement therapy was used by 200,000 heroin addicts in 1,069 methadone maintenance clinics in 2005. Methadone is ideal for heroin addiction because it is longer lasting but not as strong, allowing the addict to slowly decrease usage without the withdrawal symptoms. Methadone can be dispensed without the danger of the high-risk lifestyle that has led to infection of IV drug users with HIV and hepatitis C. However, there are many in the treatment community that do not like treating one addiction with another drug. Buprenorphine is used to treat heroin addiction through a high-dose sublingual tablet. At high doses, buprenorphine acts as an opioid receptor antagonist. Subutex is used during the early stages of detoxification, and Suboxone is used during the maintenance phase. Suboxone can be used to stabilize the user when they are detoxifying for methadone maintenance. Sedative and tranquilizer abusers tend to be older, white, and female. 41% of tranquilizer abusers and 33% of sedative abusers in treatment report concurrent alcohol use, while 18% report the use of marijuana. Most detoxification of sedative hypnotic addiction requires substitution therapy. This is done mostly with long-duration phenobarbital. Butobarbital may be substituted for phenobarbital, and dilantin, tegretol, or Neurontin may be administered to prevent seizures. This type of medical management must be done daily. Abstinence of sedative hypnotics requires intensive participation in group, individual, and educational counseling. Some addicts report bizarre taste and visual distortions for several months. Some report violent mood swings to rage or anger. Rebound withdrawal symptoms are reported by some addicts for several months after the initial withdrawal, despite total abstinence. SSRIs and Buspar are sometimes used to address the underlying psychiatric problems that led to the use of sedative hypnotics in the first place. 21.5% of all treatment admissions are due to alcohol. In 17.5% of the cases, there was a concurrent abuse taking place. 61% of the time, the concurrent abuse substance was marijuana. Alcoholics, more than any other addicts, have a hard time admitting that they have a problem. They are in denial. Part of this is due to the interference between alcohol and judgment. They don't see the association between alcohol and any of their problems. Detoxification from alcohol is one of the more medically dangerous detoxifications of any of the psychoactive substances. Not heroin, alcohol. For an individual coming off alcohol, the withdrawal symptoms are very uncomfortable. Delirium tremens, confusion, hallucinations, agitation, uncontrollable tremors, and paranoia. It ain't pink elephants. It's usually monsters. Seizures, these symptoms begin 2 to 3 days after the last drink and begin to dissipate after 5 days. So you know you're a big-time alcoholic if you go through delirium tremens and then have seizures. Alcohol withdrawals can be treated with barbiturates, benzodiazepines, Librium, paraldehyde, chloral hydrate, phenothiazines, Antabuse, naltrexone, and Camprol. Counseling is usually in the form of group meetings such as Alcoholics Anonymous. Psychedelic abusers are usually white males and under the age of 24. Since only marijuana lends itself to daily use, the treatment is most often focused on the problems that result from the abuse: intoxication, mental disorders, family dynamics, social consequences. Often the initial medical emergency that has to be handled is a bad trip or an acute anxiety reaction. Paranoia, fear over loss of control, feelings of grandeur leading to dangerous behavior. One technique to use in this circumstance is the ARRRT talk-down technique. If the technique doesn't seem to be working, medical intervention is needed. PCP and ketamine users will sometimes display violent or even belligerent behavior, even with ARRRT. Oops. And this is what AARRT stands for. Acceptance, first gain the user's trust and confidence. Reduce stimuli, get the user to be to a quiet, non-threatening environment. Reassure, educate the user that they are experiencing a bad trip. Assure them that they are in a safe place with safe people and they will be all right. Rest, help the user relax. Use stress reduction techniques such as slow, deep breathing or relaxing muscle groups, and let them rest. Talk down, discuss peaceful, non-threatening subjects with the user. Avoid any topic which seems to create more anxiety or a strong reaction. With an increase in the THC in marijuana, more and more individuals have entered treatment for marijuana dependence. Symptoms of marijuana dependence include sleep disturbances, appetite disturbances, headaches, irritability, anxiety, emotional depression, mild tremors, and muscular discomfort. Cravings for marijuana may last for months or even years. Remember, marijuana is fat soluble, so it gets into your system and it's real tough to get it out. As with most of the behavioral addictions, gamblers tend to be in denial about their problem, feeling that it is more a cash flow problem rather than an addiction. Most gamblers won't admit that their gambling is a problem until they have hit bottom and they seek treatment to placate their creditors. Gamblers experience withdrawal symptoms that are similar to alcoholism: restlessness, irritability, anger, abdominal pain, headaches, diarrhea, cold sweats, insomnia, tremors, apprehension about well being, and intense desire to return to gambling. The key to effective eating disorder treatment is early intervention before any permanent damage is done. Diagnose and treat any medical complications. The client should be encouraged to exercise and eat a balanced diet. Use therapies to change false attitudes and perceptions. Encourage attendance at Overeaters Anonymous or other 12-step groups. Use behavioral and group therapies to encourage weight gain or loss. Enhance self-esteem, independence, and development. Treat and educate the whole family. Even with the intense treatment, only 54% respond to treatment after 12 years. Severely ill anorexics must be hospitalized. Nutritional recovery will take as long as 10 to 12 weeks. The complexities of anorexia require a team approach. The patient will not improve their eating behavior until the underlying depression is treated. Of the 3 eating problems, bulimia is the most difficult to detect because the sufferers tend to be in a normal weight range. Unfortunately, due to the intake of foods with high fat and carbohydrate content, atherosclerosis and diabetes are often the result of the binge eating. Treatment will require a team of professionals, an internist to advise on medical problems, a nutritionist to help with diet and eating patterns, a psychotherapist to change attitudes and behaviors, a psychopharmacologist to monitor psychoactive medications. People suffering from binge eating disorders seek treatment for both physiological and psychological underlying causes. Current treatment include counseling sessions that focus on changing attitudes and ideals, examine underlying traumas, recognize stress and environmental cues that lead to unhealthy eating habits, pharmacological treatment, SSRIs, naltrexone, anti-seizure medication, surgical intervention, bariatric or gastric bypass, and these are the types of bariatric surgery procedures. There's a lap band, gastric bypass where they go around the stomach, a gastric sleeve where they make it a tube rather than a stomach. Can't fill it up. Individuals with self-addiction, sex addiction tend to feel extreme shame, guilt, anxiety, and depression. Organizations like Sexaholics Anonymous alleviate the negative feelings by showing the sufferers that there are millions with similar problems and that their behavior is not unique to them. Mental health professionals realize that the abstinence model will not work with internet problems since the connectedness has become universal in today's world. Most mental health professionals suggest a harm reduction model. 10 suggestions that might help internet addiction: move your computer to a different room, never go online alone, create an internet usage log. To break the isolation, tell people about your problem, exercise regularly to overcome sedentary habits, never use an alias, take an internet holiday, stop dwelling and obsessing on internet use, help someone else control their internet addiction. Get professional help. Male treatment admissions outnumber female admissions 2 to 1, 68% to 32%. Males are more likely to enter substance treatment through the criminal justice system. However, women tend to progress to addiction more rapidly. They die at a younger age. They are less likely to ask for help or receive it. Men are more likely to blame external events outside their control of their problem, while women blame their problems on themselves. Treatment often focuses on attacking the denial that many male addicts employ. This merely reinforces the self-blame in women. Men require confrontation, but women actually do better with more supportive and less confrontational treatment techniques. Women have to be supported with childcare and transportation, whereas these problems are rarely issues with men. The three greatest barriers for women seeking addiction treatment: inability to admit the problem, about 39%, lack of emotional support from family members, 32%, inadequate child care while in treatment, 29%. The earlier the onset of drug use in an individual, the more likely they will have drug problems in the future. Delaying alcohol or drug use into the 20s almost completely truncates the possibility of chemical dependence. Adolescents suffer from drug use because they have less body water fat than adults do, the immature enzyme metabolism systems. If genes dictate addiction, they become addicted immediately after use. They're more vulnerable to environmental stressors. They have had less time to develop life skills and healthy coping mechanisms. The brain develops slowly from back to front. The brain isn't an adult until around age 25. Adolescents are less able to control compulsive drug use. Treatment for adolescents requires that the regimen be broken into smaller, more quickly achieved segments because of a shortened attention span and the inability to process complex information. Adolescents tend to exaggerate the benefits of an action and denigrate the risks. Adolescents are less likely to accept the advice of an adult over the logic of their peers. Interventions must include their peers. Adolescents tend to use the drugs their peers are using. Drug use is a status symbol. Rave drugs were popular in the 1990s, peaking in 2001 and declining ever since. By 2005, 11.5 million Americans had tried MDMA. This included junior high school students as well as college and high school students. The present generation are more likely to abuse prescription medications. There's a strong association between prescription drug use and the use of alcohol. Adolescents who abuse prescription medications are many times more likely to drift into more serious addictions. Currently, there are 37 million Americans 65 and older, including me. I'm 74. Baby boomers were the adolescents on the cusp of the drug movement in the United States. They will be more likely to abuse prescription drugs and alcohol in the future. Of the seniors who present themselves for treatment, 80% are treated for alcohol abuse. Only 17% of the 80% are using a secondary illicit substance. Reasons the elderly abuse drugs. Increasing number of illnesses exposes them to more and more prescription drugs. Physical resiliency declines with age, allowing psychoactive substances to have a greater impact. Physicians maintain many misperceptions about the elderly. Grandpa or grandma won't abuse drugs or alcohol. It's too late to address addiction. Seniors have earned the right to abuse drugs. They are either too smart or too burned out to treat. There is not enough time to treat the addiction before they die. Inadequate training in geriatrics and dependency issues. There are age-related physiological changes that increase drug toxicity, decreased gastrointestinal acid secretions, motility, and blood flow, decreased lean body mass, decreased plasma albumin to bind to drugs, decreased hepatic blood flow and increased hepatic cell damage, decreased metabolism due to decreased enzymes in the stomach and liver, 1/2 to 2/3 the metabolic rate of middle-aged adults, decreased kidney function, increased receptor site sensitivity resulting in more extreme reactions in the brain. There is inadequate social and support services for the elderly to alleviate the feelings of isolation and loneliness, retirement, ageism and inactivity, rejection, disrespect and abandonment, relationship problems, death of spouse and friends, decreased satisfaction with the quality of life, financial and housing stress, coming to terms with chronic illness, pain or impending death, loss of physical appearance and abilities, frustration over memory loss, The community enables the elderly to manage their own problems. Treatment for the elderly takes a different tack than for the general population. The elderly react more positively in groups than individual treatment. They respond better in groups their own age, but can flourish in groups with mixed ages as well. Withdrawal symptoms for the elderly tend to be more severe, but can usually be managed successfully. The elderly are more likely to suffer cognitive impairment from their substance use. African Americans represent 12% of the U.S. population, but 22.1% of the admissions at substance abuse treatment facilities. Male African Americans outnumber females in treatment 3 to 1. Female admissions are more likely to involve hard drugs, while males are more likely to involve alcohol. African Americans seek treatment for marijuana use at a high level, 22% of male admissions and 6.6% of female admissions. Unfortunately, African American completion rates are below the national average at 17.5%. Reasons for African Americans having lower completion rates: higher pain threshold means that they are less likely to reach out for help and therefore enter therapy with more severe addictions. In inner-city neighborhoods, drugs represent an economic resource, making them more acceptable in the community. Crime is the first step into the drug subculture in the inner city. Strong sense of boundaries, where intervention is an encroachment and violates personal choice. Chemical dependency is often seen as a secondary problem in the environmental issues of living in the inner city. Conspiracy that such epidemic problems as crack and AIDS have been swept through the African American communities are planned genocide. The strength of organized spirituality has helped promote recovery. Currently, 14.4% of the population is Hispanic and represents 13.7% of the population in the substance abuse treatment. Alcohol is a substance that was abused to lead to treatment for Hispanics. 77% of admissions among Hispanics for treatment are male. One challenge for treatment facilities is to understand the vast diversity among Hispanics in the United States and to be culturally sensitive to the different groups. This can be done by attempting to gauge the level of enculturation represented in their client. Of all the groups in the United States, Asians and Pacific Islanders represent the most diverse group. This group literally represents all but the American Indian race in the world and some of the oldest cultures in the world. Treatment has to take into account length of time in the United States, as well as cultural and intergenerational conflicts in therapy. Asians are more likely to respond to licensed professionals rather than lay peers. Asian cultures tend to separate males and females, and therefore mixed groups are less effective. Protection of family honor is a high priority among most Asians, and therefore the counselor will see a high level of family enabling and rescuing that delays the addict's entry into treatment. Therefore, any treatment plan dealing with Asians must include family treatment as well. Drug use by nationality from most serious to less serious. Chinese tend to have problems with tobacco and alcohol. Japanese tend to have problems with alcohol, marijuana, tobacco, crack cocaine, and methamphetamines. Koreans tend to have problems with alcohol and crack cocaine. Filipinos tend to have problems with alcohol, marijuana, and cocaine. Vietnamese tend to have problems with tobacco, marijuana, and alcohol. And Cambodians tend to have problems with alcohol, tobacco, crack cocaine, smokable methamphetamines. Half of all the American Indians in the United States live in Arizona, but as a population they represent the most diverse group of any of the racial groups. The bête noire for American Indians seems to be alcohol, as 58.5% of admissions into treatment facilities deals with alcohol as compared to only 39.2% among the general U.S. population. Successful treatment often involves being culturally sensitive to more traditional American Indians. However, since over 60% of American Indians live away from their traditional lands, level of cultural adherence should be gauged to facilitate treatment. One group that is heavily represented in drug and alcohol treatment is the lesbian, gay, bisexual, and transgender community the LGBT community. 20 to 35% of this community reports heavy alcohol use compared to 10 to 12% in the heterosexual community. Part of the LGBT lifestyle in urban settings often involves bar scenes and parties that promote drug and alcohol use. However, researchers have determined that a greater predictor of alcohol and drug abuse in the LGBT community are genetics and childhood stress. One of the difficulties in dealing with the LGBT community is involving the family of the sufferer in the treatment. Often these individuals are either in the closet or estranged from their families. The biggest obstacles to treatment are denial and lack of financial resources. Many users have delayed emotional development due to the effects of the psychoactive substances, which keeps them from learning how to deal with life's problems. It is an empirical fact that brain cells are damaged when using psychoactive substances, which leads to cognitive deficits during the first several months of abstinence. 30 to 80% of substance abusers have mild to severe cognitive impairment. It is possible that some recovering clients may not comprehend the interventions that are being used with them. For this reason, most difficult and abstract concepts that are presented at the end of treatment, when the client is more likely to comprehend the concepts. And that is finally the end of the lecture. And so I'll talk to you next week. It'll be the last lecture. We'll talk about psychopharmacology.